Good afternoon, everyone, and I want to thank everybody for attending our twice a week updates on COVID-19. We do these to try to keep everybody up to speed on this and to share what we know and what's changed over the last few days since we had our last update. The thank you today goes out to our communities who have really been doing great work in supporting us. They've been making masks for us. The Croix family let us use the bus garage over at Voyager Bus to put one of our COVID testing sites in. And the restaurant from across the street has bringing food to the people over there. The outpouring of support and just of I can't use any word other than love that we've gotten from our community has been absolutely wonderful. So I wanted to thank our communities for doing this. And I hope when you're out and people come up to you and thank you for the great work that you're doing, that you express our thanks back to them as well. We have a lot to cover today because stuff has changed since the last time we met. So I'm going to spend some time on the expanded diagnostic testing criteria that have changed since the last time we got together. One of our infectious disease specialists, Dr. Amanda Noska, is going to talk to us about serology testing, what that means and why it's really not the panacea that some people make it out to be. Our modeling group is going to give us an update, and I'll have some time at the end to go through some of the questions you were kind enough to submit at the last time we went through this. So let me talk a little bit about our testing criteria expansion. We are trying to follow CDC and state guidelines, but the expanded diagnostic criteria are now includes all patients now, not just those small groups that we had before with COVID-19 symptoms. And those symptoms are fever, cough, shortness of breath, chills, muscle pain, headache, sore throat, and loss of taste or smell. So what will happen is when a person starts an e-visit, or they call our COVID hotline, or they're having a virtual visit with one of our physicians or APPs, they will be referred over to a testing station. So the testing can then be ordered and they'll be sent to one of our testing stations and the locations will be provided. And then they'll be able to go and get their COVID testing. We have seen a large increase in COVID testing in Essentia land and across the state. And perhaps this will give us a better idea of what's going on out there and give us a better idea for our modeling group and as well as others to predict how the pandemic is moving through the community, predict the surge, and also predict the thing that we talked about the last time, which is the case hospitalization rate and the case fatality rate, which is the percentage of us that have the infection with COVID-19 that actually require hospitalization or unfortunately die of the disease. And those are important things to know as we plan going forward. Right now, what I'd like to do is turn this over to Amanda Noska, one of our infectious disease specialists, who will go through the serologic testing and give us an idea of how that works, why that's important, and who shouldn't be tested, and why that we're kind of at a difficult time in this right now, determining the best use of this test. So Amanda, thank you very much for joining us today, and I'll turn it over to you.
Thanks for inviting me to be here. I'm just going to speak briefly about COVID-19 testing. So as many of you know, we currently have a swab that's a PCR test, polymerase chain reaction test. It detects the virus itself that causes COVID-19 by sequencing DNA, and it's intended for diagnostic purposes. But to augment that, as of last Friday, we were able to roll out a serology test, which is a fancy word for antibodies, but it detects IgG or blood tests in general. It detects IgG antibodies against COVID-19. It's really important to note that the COVID-19 IgG antibody that we have is not intended to be used for diagnosis in an acute setting or in somebody who's suddenly ill. It's more importantly used to help determine the response to a COVID-19 exposure. Okay. So what is serology testing? As I said, it's a blood-based test, essentially. It looks for the presence usually of antibodies, sometimes other things, which are produced by the immune system in response to an infection. So how do we detect antibodies? Well, it depends upon what antibody we're looking for. Sometimes we're looking for earlier antibodies, which would be an IgM antibody or an IgA antibody. In this case, the serology test that we have, the IgG antibody, is one that happens later in exposure and in the course of a disease illness. So in this situation, the COVID-19 or SARS-CoV-2 antibodies, IgG antibodies, are detected at least 8+ days after an infection. 8 to 11 days is when the body first starts to make the antibodies, and they increase in production over the ensuing time frame, with the best reliability of this test being at 14 days or beyond. So it's important to know when your patient's symptoms were, or when they were first diagnosed, if you don't know when their symptoms began, so that you kind of know when to test for this, because it really, the reliability of the test depends upon when a person first became ill, in order to know when to test, which is 14 days out. And like sorry, can you just go back one thing? So it's also very helpful in determining, we are primarily using these tests to determine whether or not a patient has been exposed to COVID-19. But as I said, it's not that useful in diagnosing a sudden acute illness with COVID-19. We have other tests for that. What else can we use the serology test for? Sometimes it's helpful to also know what not to use it for, and we'll talk about that in a minute. But what we can use it for is to look to see how common is COVID-19 in our community, because we still believe that it's not everywhere, and that it's not terribly widespread. So it's important, although it is in the community everywhere, that we know how common it is in the community or what the prevalence is. It also can help us to identify asymptomatic or what we call subclinical, so really mild symptoms like allergy symptoms, for instance, how common those types of infections are. And then occasionally it can be useful to help us sort of retrospectively, or kind of look backwards to see if a patient had a false negative test, or if they waited to come in for 7 to 14 days after symptoms began, did that person have COVID? The IgG test can help us to answer that question by testing late in a disease course. But like I said, it has to be at least 14 days out from symptoms in order to be reliable. So we have this test available. It's a very reliable test if done correctly, which means it should be done 14 days after symptom onset or beyond. And this is a test that providers need to order. So it's very important that our providers here know sort of they're the gatekeepers for the test, and they would be the ones who decide to order this based on the performance characteristics of the test. The test is called an ELISA, microplate-based enzyme immunoassay, and it is an indirect test, which means it involves 2 different pairs of antibodies that bind to the viral antigen. So basically, a person's blood is put in a well, and then an antibody binds that. It's incubated, it's washed, and then another antibody binds it. And after that, it goes through a light response and tells us how likely it was that COVID-19 was in the sample to begin with. There's 3 options for output from that test. There's a negative. There's something called indeterminate, which doesn't mean partially positive or partially negative. It means we don't know. So it has to be redone in that situation. And then there's a positive. Like I said, the orderable is listed down here, but that's important for providers only. The providers would be the ones to order this test based on their knowledge of the test. And like I said, this is an indirect ELISA, so we have a person's blood in a well, and that has to be diluted because you don't need that much blood. But the COVID-19 antigen would sit in that well. Then we would give, the lab does a special series of incubation and washes, and antibodies are bound to, they're designed to be antibodies that specifically bind COVID-19. The antibody is put in there, incubated again, washed again. A second antibody with a tag, that E that you can see in the third well there, is a tag that helps us to get the sample to light up. And then at the last part, there's a light response that tells us whether or not something is positive. So what does this lab tell us and what doesn't it? Well, we talked about what it does, but I think the most important message, at least for today, April 28th, is we cannot tell you with certainty that this tells us anything about immunity or immune protection. And the reason is the immune system relies on a specific type of antibody called a neutralizing antibody to kill the virus, and we don't know what concentration there is within this IgG antibody test. So it's important not to take away from it's important to take away from this that this test does not mean you're immune. It does not tell us that, and we can't guarantee that at this point with this test. So why would we use this? Well, for patients with prior symptoms, for instance, who had didn't have a PCR test performed before, for instance, maybe they were well enough to stay home, this would be a great test 14 days plus after symptoms to look to see if they actually had COVID when they had that head cold more than 2 weeks ago, or other symptoms. For inpatients who have a clinical presentation where we think they had COVID, but their PCR test was negative for some reason, the IgG antibody is a really good test as long as it's done 14 days out from symptoms or from presentation. And then to assess immune response, one, in immunocompromised individuals, we can look to see whether or not somebody had an immune response to COVID. And the other is an important, subset of people, which is folks who have recovered from COVID who want to donate their plasma for treatment. We have that ability here in the Duluth community, and this IgG test can help us to identify folks who might be candidates for that. So serologies are intended to be interpreted based on the time from symptom onset to the time that we actually draw the lab. And that's a really key point here because how reliable the test is based solely on that. It's very important that you keep track of when symptoms began so you know when you draw the test that this is very reliable or less reliable. Interpretation of the results then in asymptomatic people or people without symptoms is a little difficult because if you never had symptoms, we don't actually know exactly how reliable this test is. We know from 14 days after symptom onset, it's a very reliable test, but in asymptomatic individuals, there's a lot of gray area. As I said, we don't have access to neutralizing antibody titers. Those are really rigorous sort of research-based studies. But this IgG antibody is a useful first step for convalescent plasma evaluation. And then false positives have been described as a weakness to this test, although they're very uncommon. And since we don't have a lot of SARS here, or the initial SARS-CoV, we're lucky because that would be the most likely to cross-react with the serology that we've chosen to use through Mayo Clinic's lab. Both false positives and false negatives have actually been described, but they're fairly low with this particular test, the indirect ELISA. With that said, any test we ever use rests upon a few key things. One, what do we think the probability of it being positive is before you ever get the test, the pretest probability? And that significantly influences how reliable the test is, the sensitivity. What test we're using, right? So we may have seen some things on the news about rapid antibody tests. Those are fairly unreliable. They're called lateral flow assays, and they're not very reliable for diagnosis. And they're pretty prevalent within the United States right now. Timing of the test in relation to symptoms is the third variable, and we've talked about that already. So just to kind of discuss one study I think that is very good. I chose this one in particular because it's looking at a recombinant nucleocapsid protein, which is what the ELISA that we're using at Essentia is based upon, and it's an indirect test, an indirect ELISA test. But basically, I just want to point out to you that the results of this very good study out of Clinical Infectious Diseases looking at the positive rates of known SARS-CoV-2 infections for IgM and IgA were 85.4% and 92.7% 5 days after symptoms. And for IgG, 14 days out, they were only 77.9% positive. So it was not a perfect test even in this study, but it is something that will help us to move forward with diagnosing COVID-19 and to clarify some of the gray zones within our current knowledge base of COVID-19. There were another couple of strengths of this study. Of the 43 confirmed cases and 58 suspected, they were able to look at how the IgG antibody performed with those who had suspected SARS-CoV-2 as well. And we'll talk about that on the next slide. The other key thing I wanted to point out from this study is that the swab that they used, the COVID-19 PCR swab, was pretty reliable the first few days of symptoms, greater than 90% sensitive within the first 3 days of symptoms, but it was less than 80% sensitive as we got 6 days or farther out from symptoms. And for many patients, that's pretty common. And then greater than 14 days out, the swab test was much less reliable. So there we might do better with the IgG. We don't have IgM available yet, but someday we probably will. And that combination of the swab and the IgM are the most reliable way to diagnose COVID. So the IgM and IgA we've kind of talked about, but they perform the best at about 5 days after symptom onset, whereas IgG, which is the test that Essentia has rolled out as of Friday, performs best at 14 days or farther out from symptoms. And the positivity rate, even in this very good study, was only 78%. So it's not, like I said, a perfect test, but it is very good. The other thing is the IgG test was quite good at helping to diagnose persons under suspicion for COVID who did not have a positive PCR test. So that's another utility. So we're going to continue to study these. We've done quite a bit of looking into this already, and I'm confident that the test that we chose to go with in our lab is a very good test, and it's reliable as long as it's used as we described it, 14 days after symptom onset. And we will provide you updates as they are available.
Thank you very much, Dr. Noska. I was going to joke with people, there's going to be a test after this about, the secondary or two-step ELISA, but we won't send people out a test on this. We're doing that. But thank you very much, and thanks for following along, and thanks for all the hard work. I know that you've been, 24/7, 7 days a week here, keeping everybody safe, and we appreciate that.
My pleasure.
I'd now like to, thank you. I'd now like to throw it out to Sarah Manny and the predictive modeling team again to give us an update of where we are with that. So Sarah, I'll turn it over to you.
Great. Thank you, Dr. Herman. We are pleased to talk to you today about the MHA predictive models and some changes that we've seen in the model. We're also going to discuss the regional projection model. And in addition, a brief conversation about the nature of surge and modeling waves after that. Next slide, please. I'm going to turn it over to Steve Waring to discuss the waves. Thank you.
Sure. Thanks, Dr. Manny. And thanks, everybody, for being here today. And thanks, Dr. Noska, for bringing that incredible, important piece of the puzzle to Essentia and your careful attention, you and Dr. Prabhu, on getting the right test that we can rely on. Much appreciated. So what you're seeing in front of you is an infographic that actually came out of the 1918 pandemic, which really was the last really big global pandemic we had. So here it is about 100 years later, and we're going through this again. But what's interesting you see here is that even back then, that shaded area that you see around those curves is the duration of social distancing measures. So even back then, that was a recognized way to try to control epidemics. And so I draw your attention to maybe Pittsburgh, which is the first in the top left-hand corner there. And they ordered social distancing measures much later and for shorter periods of time. So you can see, their curves really weren't affected. The thing peaked, it raged out of control, and then it kind of went away. So it kind of burned out. When you go down to the opposite end of the chart here, down in the lower right-hand corner, you see the wonderful city of Minneapolis Of the cities that did it right and did it long enough for longer periods of time, it really had a major effect on that flattening of the curve. And of course, as you see, there's more than one curve, but the good news is that by social distancing being in place, it allowed that to stay at a level where it was much more manageable and much less of a what we saw in Pittsburgh. And just proof that, we have a tradition in Minnesota for a long time that we do the right thing at the right time, and we follow directions really well. So I think that's a good testament to who we are and what we do. So maybe that'll hold well for us again this time around.
Thank you so much, Steve. Next, we're going to transition to Niall and Elena. Thank you.
Yeah, I'll go ahead and start really quick. This is Elena Wilmot with Enterprise Analytics. I'm going to take the screen here. Should be showing up here in just a moment. Okay. So again, this is sort of the regional projection model. We showed this last week, a couple different changes we wanted to highlight briefly. We can see this upper right graph has been really useful for us to watch the number of case counts in our markets and how they're comparing to some other locations. Cedar Rapids, Iowa is a location, has a similar population, but Iowa does not have a stay-at-home order in place. And we can see how our West market is growing pretty rapidly compared to both our East and Central markets. And we can see how the East market has continued to track very closely with the experience in Rochester, Minnesota. And I'll just point out down here on the bottom right, we have number of new cases each day. And so we can see these vertical lines indicating when the Minnesota stay-at-home order was in place and when Governor Walz indicated that Minnesota was going to start increasing testing. And we can see here we have seen an increase in number of cases we're reporting on a daily basis. And if I just switch really quickly here to the percent of tests that are positive each day, we can see since that increased testing, the percent has gone down, which is just an indicator of more tests being done. So that will be another interesting thing for us to watch in the coming weeks with that increased testing. That's all I have. I'll hand it over to Niall.
Thank you very much. And you should be seeing my screen now, looking at the Minnesota Hospital Association model. Not a great deal has changed on this since we last spoke on Friday, but I did want to provide you a fresh look at it because this is how we present it every week to the system IMTs and to the market IMTs and the surge committees. And this is our own internally baked up dashboard put together by Lane Trisco. And it allows us to go in and look at some of these predictions from the Minnesota Hospital Association model and some of the projections. And it also does something that's important for us right now, which is it allows us to look at a few different scenarios sort of simultaneously. Right now, what I've done is I've selected all of Essentia. So obviously we can drill down into a market or even down to a location level. And then what you're seeing in dark red here is a projected census for med-surg beds. And so this is across all of Essentia. And as you see, as we get further out, you'll see these shaded lines. And these shaded lines aren't what you might be used to seeing like a confidence interval. They actually represent different scenarios based on different estimates of what might happen in the future. And obviously the reason for that is once the stay-at-home order is either rescinded or changed or kept in place, we'll have some more information about how the virus might spread through our communities. But up until then, we sort of have to do our best estimates based on what we've seen before. So our default look here for the system IMTs is to just look 8 weeks out, but we do allow it to go further out. And I'm going to do this just so that you can get a sense of how different these scenarios play out over the long term. Now, at the moment, our doubling rate in Minnesota is somewhere between 10 and 15. When we put the model together last week, the Minnesota Hospital Association CMIOs meet every Tuesday, so we're actually meeting right after this to discuss the newest data and the newest research findings. We found it at about 15-day doubling period based on what we were seeing in the data. And so That goes out till May 4th, and then we do 3 different scenarios. This first large peak that occurs, this first wave that occurs in July, as it's currently projected, that's what would happen if we went to a doubling period of about 5 days. And that's longer than we saw at the beginning of all of this in Minnesota, but quite a bit shorter than it is right now. This dark line represents 8-day doubling period, and that's sort of a middling estimate. All of these we think are reasonable, possible outcomes, but obviously there's a great deal we don't know. And the one I want to highlight here is this lowest med-surg bed, and this would be what would happen if we stayed at this 15-day doubling period that we had been seeing this past week or so. And you can see how much of a difference, both in terms of when this first wave might occur and also how large this first wave is and our ability to meet it with our planning and all of the great work that the surge committees are doing. Now, again, we can drill down into different locations. And one of the questions we get often is, does it make sense to be grouping over this big population? And obviously it doesn't make sense to go all the way from West Market to East Market as one big population. One of the things we like about this model is our ability to regionalize. But once we get down to a narrow facility area, it gets a little harder to accurately model. And so what we've decided to use is this hospital referral region. And this is just patterns of hospital use that have occurred historically. And it's a geographic map that's put together by Dartmouth. And it maps fairly closely to the way we use our markets at Essentia. There's some discrepancies there. And so we're always doing background modeling as well, just to make sure that we're getting the best estimate we can, given the information that we have right now. Dr. Manning?
Thank you, Niall. I appreciate that. Next slide, please.
Did it come back to me to share yet? Let me see if I can share my screen. Let me go to there. Go to there. All right.
Wonderful. Thank you. And Niall, thank you so much for clarifying that question. This is a question that we received after our last presentation. And so, like Niall explained, we use the HRR, or the hospital referral region, to help define our modeling. But one important thing that's we want you to know is that surge planning is happening. It's very active. We're taking into account all of the smaller hospitals and regions when it comes to surge planning. So just please be reassured, and also know that our team is looking at this regional and smaller hospital data on a daily basis. Thank you. Dr. Herman?
So everybody's clear that we are modeling the whole thing, but if we try to get it down to, say, Cook, Minnesota, the population is just so small that it's really hard to model a population like that. And then we have did you want to talk about the e-learning coming out, or would you like me to do that, Sarah?
Oh, thank you very much. We do have an e-learning that will be coming out next week that will help model the wave and subsequent peaks that we may see. So more to come on that, and we will share it with you when it becomes available, hopefully next week.
Thank you very much. So there's questions that we got from the last time, and in the last few minutes here, I'd like to cover some of those questions. So question number one is, in one of the recent webinars, it was mentioned that wearing bonnets and shoe covers are not recommended, as we need to keep these for OR staff as our PPE supply permits and allows. I know that a neighboring facility is using cloth head coverings that a staff member has made. Would this be permissible and possibly an option if staff wanted to do this? So I reached out to our infectious disease colleagues on that, and Dr. Prabhu's answer was people are already wearing homemade cloth head coverings at St. Mary's Medical Center and a lot of other places. It's very pervasive. So as long as you launder it, not wearing the same one every day, and you launder it in between, it's okay to do that. And so go ahead and do that. The second question is, how are we keeping our colleagues who are on special administrative leave informed about COVID-19 updates? And Diane Davidson, the head of our HR group, sent a memo to all colleagues on a special administrative leave last week talking about the importance of staying connected with the information that we provide every day. She outlined several resources for our colleagues and mentioned our COVID-19 SharePoint in particular. So employees on leave can use their Essentia Health login to access the COVID-19 site on the source. Then go to essentiahealth.org and scroll to the bottom of the home page and click on For Employees, and then do your login. And then that will give you access to the SharePoint site. And then you can see the daily updates, the screening questions, and all the other things are out on that site. So that would be a great way for our colleagues on special administrative leave to keep things going with that. Here's a great question. It says, I've been making cotton personal face masks for coworkers. There was a physician online stating that surgical fabric used to wrap surgical supplies, Halyard H600, is recommended for making fabric masks. If this is felt to be legitimate, can the hospital provide any of that for those of us who are making masks? This has a short answer and a long answer. So the short answer is yes, we can provide that. And people can reach out to Brian Zuck, and we'll have a way we can do that to get that H600. But he did want to comment on the H600 piece. You know, the bacterial efficiency of these fabrics varies, but in all cases, they are the same or better at higher level than our surgical masks. However, that said, they're not tested for fluid resistance as our surgical masks and other masks are, and the supplier will not stand behind that H rating, that H100 or that H600 rating when we've turned these wraps into masks. So it makes them from equivalent to a cloth mask as to who can use these. So people that are in non-patient care settings, our patients and others would be able to use these masks. But those of us that are required to use a surgical mask or a high-level mask would not be able to use these masks in lieu of one of those higher-level masks. But thanks, that's a great question. So we've come to the end of our time here. We actually have gone a minute over, but in future sessions, please email your questions to liveupdatequestions@essentiahealth.org. We do our best to collate these questions and answer these questions. I find them very helpful, and it's very helpful, and it also helps us to plan out what are the topics that people have the most questions about. So our next meeting is this Friday, May 1st, May Day at noon. I want to thank everyone out there for your great questions, for your great help, for the support of your colleagues, our patients, and the communities we're privileged to serve. As we hear from people in the community that thank you, please thank them for their support of you, our colleagues, and of Essentia Health. So looking forward to see you next Friday. And as always, everybody, please stay well. Thank you so much.